Greetings, I'm Dr. William Lanier of Mayo Clinic Proceedings, and I welcome you to the multimedia summary of the journal's March 2017 issue. This month there are 4 articles that have been designated Editor's Choice or Highlights selections. Our Editor's Choice this month is an original article authored by Dr. Wang and colleagues representing Capital Medical University in Beijing, China, and Massachusetts General Hospital in Boston, Massachusetts. The authors discuss the implications of non-obstructive coronary artery disease, defined as less than 50% stenosis, among patients undergoing coronary angiography or coronary computed tomography angiography. Their research included studies that reported on the prevalence or prognosis of patients with non-obstructive coronary artery disease among patients with known or suspected coronary artery disease. Patients with non-obstructive disease were further grouped into 4 categories, including those with no angiographic coronary artery disease and those with various degrees of mild coronary artery disease. In their final data analysis, they evaluated 54 studies and data from almost 1.4 million patients. The prevalence of patients with non-obstructive coronary artery disease was 67% among patients with stable angina and 13% among patients who had non-ST segment elevation acute coronary syndrome. The prevalence varied depending on sex, clinical setting, and risk profile of the population investigated. The authors found that the risk of hard cardiac events, which they defined as cardiac death or myocardial infarction, was lower in patients with mild coronary artery disease than in patients with obstructive coronary artery disease, but higher than in those with no coronary artery disease. They concluded that non-obstructive coronary artery disease is associated with a favorable prognosis compared with obstructive coronary artery disease, but determined that non-obstructive disease is not benign. Thus, in the opinion of the authors, non-obstructive coronary artery disease warrants further efforts to improve risk stratification and management. This article is introduced by an editorial authored by Dr. Rumberger from the Princeton Longevity Center Cardiac Imaging in Princeton, New Jersey, and entitled Coronary Artery Disease, a Continuum, Not a Threshold. Dr. Rumberger discusses the origins of preponderant concepts of coronary artery disease and offers alternative interpretations of the pathophysiology and terminology. He notes that the greater the extent of coronary atherosclerotic plaque involvement, the greater the risk for future coronary-related clinical events. But even patients who have no obstructive disease can still experience some risk. Our first highlight article in the March 2017 issue of the Proceedings is an original article that examined the stratified and joint associations of physical activity and the number of chronic conditions on long-term all-cause mortality. It is authored by Dr. Martinez Gomez and colleagues representing the Department of Physical Education, Sports and Human Movement at the Universidad Autónoma de Madrid in Madrid, Spain, and other operations in both Madrid, Spain and Florence, Italy. They evaluated data from a cohort of 3,967 individuals representative of the non-institutionalized population of patients 60 years and older in Spain during the period 2000 to 2001. They used self-reporting of physical activity to classify patients as either inactive versus active occasionally, monthly, or weekly. They compared these data to 11 chronic conditions diagnosed by a physician. The authors concluded that physical activity was associated with a reduction in risk of death associated with the coexistence of 2 or more chronic conditions in older individuals. They suggested that future research is needed to examine the role of physical activity in improving health outcomes in aging populations, and this research should focus on individuals with specific geriatric preponderant diseases such as frailty, disability, falls, and incontinence. The second highlight article in this month's issue is an original article authored by Dr. Arena and colleagues from Mayo Clinic in Rochester, Minnesota. Dr. Arena is now affiliated with the Department of Neurology at Flini Institute, Buenos Aires, Argentina. The authors review long-term outcomes for patients experiencing transient global amnesia. Using the Rochester Epidemiology Project database, the authors retrieved data from all patients diagnosed with possible transient global amnesia in Olmsted County, Minnesota, between January 1985 and December 2010. 221 patients were identified, and 221 age and sex-matched controls were included in the analysis. The mean duration of follow-up was 12 years in both groups. Prevalence of vascular risk factors and history of seizures were similar between groups, but previous migraine was more common in the transient global amnesia group. There was no statistically significant difference between survival curves for the transient global amnesia group and the control group using time to any type of cerebrovascular event, time to seizure event, or time to cognitive impairment event. The authors noted that transient global amnesia recurrence occurred in 5.4% of patients after a median interval of 4.2 years. The authors conclude that having an episode of transient global amnesia does not increase the risk of subsequent cerebrovascular events, seizures, or cognitive impairment. The third highlight in this month's issue is the next installment in the Symposium on Neurosciences. The article focuses on Guillain-Barré syndrome and is authored by Drs. Vadix and Klein from Mayo Clinic in Rochester, Minnesota. The authors define Guillain-Barré syndrome and describe its history, pathogenesis, clinical presentation, treatment management, and available preventive measures. They note that management is supportive and may benefit from immunomodulating therapy. Many patients will require prolonged intensive care and long-term neurorehabilitation. Without a full understanding of Guillain-Barré syndrome's pathophysiology, it will be difficult to find a treatment that dramatically hastens the slow recovery trajectory, which may take years to optimally resolve. Most patients will have a good outcome, including the possibility of full recovery, but disability will remain in up to 10%. This article also offers continuing medical education credit. For readers who complete the test and appropriate documentation, up to 1 hour of CME credit can be obtained. As always, you can access these fine highlights and editor's choice articles free of charge during the entire month of March. Please visit our Mayo Clinic Proceedings website at www.mayoclinicproceedings.org and review some of the other free content there. You can access the social media buttons near the top of our homepage to follow us on Facebook, Twitter, and YouTube, where you can remain current on online first publications that are introduced on our website between the monthly issue updates. Our website also lists many news stories that are based on articles published in Mayo Clinic Proceedings. On YouTube, you can find video content such as full author interviews, our 60-second video article summaries, and also our Mayo Clinic Proceedings fireside chats, which are available through iTunes in addition to access from our website. As always, thank you for your interest in and support of Mayo Clinic Proceedings. We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.